Hello, everyone. My name is Steve Van Wormer from PHAWARE Global Association. We want to welcome you to this webinar, Zoom webinar called Transitions and Trials in Pulmonary Hypertension for Young Adults age 16 to 21. This is a webinar, like I said, from PHAWARE and our friends here at the PPHNET. I'd like to welcome this great panel of doctors we've assembled from all across the country. Dr. Eric Austin from Vanderbilt, Rachel Hopper from Stanford, Mary Mullen from Boston Children's Hospital, and Nidhy Varghese from Texas Children's Hospital. And they're here to take your questions as we talk about, as I say, transitioning and clinical trials in young adults with pulmonary hypertension. So, doctors, thank you so much for joining today. Also, sorry. To tell you a little bit about these docs are all part of the PPHNET, the Pediatric Pulmonary Hypertension Network. If you're not familiar with the PPHNET, they just launched redid a great website, pphnet.org. This is a network of hospitals across the U.S. and Canada, individual centers, but also individual doctors, and they are committed to improving the health, quality, care, and outcomes of children with pulmonary hypertension by enhancing collaboration among these centers in order to develop and apply novel strategies for early recognition and initiation of treatment to reverse, prevent, or even slow down the progression of disease. They promote and conduct collaborative activities in research, education, training that leads to the development of effective therapies and their successful application. And consistent with the very nature of these of the pediatric population they serve, a network is aimed to ensure membership of the network activities are inclusive and diverse. Is that a good overview? I'll defer to Mary on that.
Absolutely, that's a great overview.
Well, I thought what we do to those attending, you have on the webinar feature here at the bottom of your screen, I believe there's you should see a question and answer bar, or you can raise your hand. Just feel free to do that at any time, and we'll get those questions answered the best we can. And we're going to treat this more as kind of an open discussion on this topic, and kind of break it down into the two areas here. And maybe we'll start in the idea of transitioning when these kids are getting kind of aging out in some cases from their pediatric centers, and how they kind of are released into the wild into the adult center. And then on the back end, bottom of the hour, we'll talk a little bit about clinical trials and how that also applies to this population. So without further ado, I will defer to Mary and Nidhy, who I think are going to kind of tell you a little bit about transitioning.
Wonderful. Thank you so much. Mary, do you want to start off? I'll get the slides up.
Sure. Thanks, Nidhy. Well, first of all, we're really excited to speak about transition because transition represents some of the successes of our program in our treatment of pulmonary hypertension in children. So we wanted to talk a little bit about exactly what is transition. And why is it so important for our patients? So of course,
are you seeing the right presentation?
I am.
Okay,
perfect. Perfect. Great. Thank you, Dr. Varghese. So transition really represents evolving care. And there are many types of transition in medicine. A patient can transition from outpatient to inpatient care, transition from taking one medication to another, or transitioning from one provider or practice. And I would even add one type of practice to a different type of practice. Nidhy, do you want to?
Sure.
Go ahead.
So thank you so much. So transition is a big deal. Any type of change can be challenging, and inherent to change is risk, because there's a vulnerable time period, because you're moving from one thing that you perhaps know to something else. And so transition increases risk of not having the usual support system. You may not have that readily available. And specifically with medical transition, there can be risks that can be clinically significant, right? It can affect the way that you take care of yourself or your disease control. You may not have access to medical care as easily because you're not familiar with the due process. You may need medications or refills and not know how to get them. The records may not make it over before you do. And so then you've transitioned, but only you have transitioned and your medical records haven't. And then when you transition, it's meeting new people who don't know you, who don't know what you've been through, have not experienced your disease with you. So that loss of experiential history can be really unsettling. And those, all of these features that are kind of unique to medical transitions can really add some extra risk during what is already a vulnerable time period. And when we look at pediatric and adult care health delivery, it's different. They're not the same, but they're continuous. It's on the same spectrum. So pediatric care starts off with a very family-oriented approach. As pediatricians, we rely on significant parental involvement in decision-making. And we often have a lot of resources available to us in our clinics or in our practices that can help the overall holistic child. So that usually includes social workers, dietitians, there may be respiratory therapists, et cetera, who are all embedded in the clinic and readily available and accessible to the pediatric patient and caregivers. On the other end of this continuous spectrum, though, is adult care, which comes after a time of increased responsibility and independence, and so tends to be more patient-specific, not family-oriented or family-specific. Adult care requires autonomous, independent skills of patients to care for themselves and to advocate for themselves. And there are often less interdisciplinary resources available to patients in the adult care model, which really requires the adult patient to work hard to seek them out or to follow up when those referrals are made. So pediatric and adult PH, though, are also different. Mary, do you want to talk about this a little bit?
Sure. First of all, the etiology of pulmonary hypertension is different in children from adults. There may be specific unique causes of pediatric pulmonary hypertension, including chronic lung disease or bronchopulmonary dysplasia in ex-premature infants with pulmonary hypertension, patients who have congenital heart disease, or are close to having congenital heart disease, patients who have specific connective tissue disorders, and patients who have genetic mutations. Many of those things are also found now in our adult population, but the causes overall are different. In children who receive pH-targeted therapy, survival has been reported to be greater than 90% at 6 years, which is wonderful. And children who transition to adult care may also have other associated childhood illnesses. So, for example, they may have diagnoses that are associated with congenital disease, which are different from those that are found in adult care. And there are a number of challenges in transition. In adult care, there may not be physicians, providers, or office staff who are as knowledgeable about pediatric causes of pulmonary hypertension. It may be different and difficult to transition with insurance, and patients may have had an insurance policy that was accepted at a freestanding children's hospital, which may not be accepted at a different hospital. Changing from parent caregiver insurance to Medicaid insurance for an individual patient could involve a lapse in coverage. And in the beginning, just as with any new circumstance, there may be issues with trust with a new office team and with hospital providers. They may not understand the history from the very beginning. And the role of parents in an adult hospital and in an adult medical practice is different. In pediatric practice, we assume that adults will accompany children or even adolescents, but that's different in adult hospitals. So all of these are really challenges that as someone approaches transition and undergoes transition, that they have to think through and surmount. So how do we approach transition? And I think perhaps we could all talk about that. In the very beginning, we were discussing together, and many of us undergo transition in different ways. Certainly, we all begin early and utilize transition tools to talk about assuming responsibility for care and what that might look for an individual patient. We always want to involve caregivers in transition because this is an important process for parents and for caregivers as well. We really want to encourage the child to take ownership of their care and to communicate with our offices and with our physicians and our nurse practitioners, our APPs. And we want to empower the children to help to take charge of their care and to develop their cares. And really, this needs to be a team-oriented process. And it begins early, but needs to occur at every visit for a successful transition. Nidhy, why don't you go ahead, Dr. Varghese?
Sure. So as I'll go back to the slide real quickly just to remind everybody where Dr. Mullen ended, that transition needs to be something that is recognized as a process. It's not a one-time thing, right? It's not that you go in for a clinic visit and say, hey, guess what? You're transitioning today. Transition is a process that often will begin in early adolescence, somewhere around 12 or so. But again, that's very personal. It depends on the person. Some people are very mature and take an active role in their disease process and in their self-care from a young age. Others at the age of 16 are beginning to get involved. So it really depends on the person. So it's really important that there's ongoing conversations that involve a process to begin and give ample time so that you really can go through all of these steps. You really can't skip one of these steps. And once we go through all this, then we can understand that when is it time to transition? And it's kind of like an internal checklist, I think, that we all have. And I tell my patients that you are ready to transition when you think you're ready, when I think you're ready, and when your family thinks you're ready. Like when everybody's got to feel ready, because there are many steps to this and many facets to transition. So the first is, it's time to transition when you know your disease and you have a basic understanding of how it affects your body. You're able to recall your medications, understand how they work for you, and know which pharmacy they come from. You can name your insurance company and be familiar with your plan coverage, right? Like what your insurance will cover, what it won't. And that you know how to recognize situations in which you need to contact the medical team, and you know how to contact the medical team, to use the phone tree, to use your electronic health record, all of those different things, to really harness all that's available to you to then communicate with your team. And a really big thing is recognizing when you're in an emergency situation and what do you do, right? Who do you call when you're in an emergency situation? What is an emergency situation? What constitutes that? So it's time to transition when all of those things can be met, all of those pieces can be met, but also when everybody is in agreement that all of those pieces have been met. So now it's time to transition. Well, then is the pediatrician's job done then? No, and it's not. Transition is completed when your appointment with the adult center has happened, when you have successfully moved your prescriptions over, you have successfully identified your new team and you have contacted them and you've had an actual visit with them, right? When there's been a complete handoff, that's when transitions happen. So part of that transition process includes identifying who you're going to work with. And identifying an adult partner is an important part of this. And when I write here, identifying a partner, because your team, when you were in pediatric care, the caregivers, the parents, they're the ones who are partnering with the pediatric specialist. On the adult side now, you as the patient are the one who is now partnering with your adult specialist. So it's a partner for your care. So you need to choose your team wisely. The practice that you are going to should be able to do all of the things that are listed here. They should be able to manage your pH with the wide spectrum of therapies that are available on the market. They should know how to work with your insurance and get your medications approved and to take your insurance. They should be able to take care of you in the hospital if you get sick and get admitted there. They should have an on-call system that can provide you 24 hours of care, 7 days a week, because things happen at off hours. And your medical staff has to be willing to listen to you. Sometimes you may try to find an adult care specialist, and it might take you a couple of tries before you find the right one that really fits well with you and you feel like you can partner with. And then one other piece to kind of to what Dr. Mullen was saying earlier is that if you have other medical conditions, you want to make sure that you're going to either a new team or a new hospital system that can still care for those other medical conditions, such as lung disease or lupus or congenital heart disease, whatever else you may have. So pediatric and adult care healthcare delivery models are different. And in adult practices, they actually, including the slide to really kind of talk about all the positives that adult care delivery models have. Adult practices have a lot more experience with and are more comfortable with topics related to contraception and pregnancy, with employment and disability, with driving, with self-care and how you juggle what you need to do to take care of yourself with what society and community demands of you as an adult. Adult centers also have access to research trials, medications which are only in medication trials which are only enrolling 18 and up, and they have access to new medications faster. And then adult care, they are very comfortable in speaking about life expectancy and planning for the future with interventions such as advanced directives, power of attorney, et cetera. And I think one of the things that's a little bit different with adult care versus pediatric care is that in adult care, you, the patient, you are at the center of the team and the center of this effort, which I really like this skydiving picture because of it, but you are at the center of it, as opposed to the pediatric where it's the patient and caregiver and families at the center of what we do. So the emphasis is a little bit different. So I'm going to summarize our talk here this morning and hope that we can have some discussion. But in summary, transition is an increasingly important part of the pediatric patient care plan. And it's a transitional process that allows for growing independence and responsibility. I like to say, you get to be part of this, right? This is an active process that you get the opportunity to have. It's not something that you have to do, you get to do, which is a really unique way, I think, to think about it. But this is not a passive process. It requires a lot of conversations with key stakeholders. That includes your pediatric team, your adult care team, the people who have been part of your care team, such as your parents, caregivers, et cetera. And involving all those people will help for a more smoother transition. And then we have transition tools, which I have listed on the next slide, but you transition tools to assess readiness so that we really can make sure that not only that the patient is ready to transition, but that everybody else in your life is also ready to move that going. And remember, transition, as I said, is a process. It's not a one-time thing. And the conversations often will continue even after transition, that transition appointment first happens for it to really be completed. And that's it. These are the transitional tools that I spoke about earlier. So if you are interested, you can look at those different websites and learn a little bit more about transition process. And if you are at a center in which transition has not been mentioned or discussed, hopefully these will help for you to spur the conversation with your pediatric care team.
Wonderful. Hey, thank you so much to both of you. Well, what's interesting about this group is a question is like you're at 4 different centers. I'm sure you all keep the overall overarching themes that you spoke about here and front top of mind. But because your center, some are tied to an adult center, some are not. I'm wondering if we could talk for a moment about how each of you kind of determine when that is, or how that transition goes for you within your adult counterpart teams, and just how that works for you guys.
I can start. So I'm at Texas Children's, which is in Houston, and I am lucky that I have a Pulmonary Hypertension Association accredited adult program just like a block away. And so I'll send a lot of patients there. However, Texas is pretty big, and we don't have for pediatric centers. The closest ones to me are in Denver, Colorado, or Aurora, Colorado, and in Nashville, Tennessee. So they're pretty far. And so I get a lot of patients from all over the country, and continuing to fly or drive to Houston is not really practical. So sometimes I'm able to send them to my partners down the street. Sometimes I can work with their with where the patient lives to find a local adult provider. The nice thing is there are a lot more adult centers than there are pediatric centers. So even though a patient is coming to me from Louisiana, because there's not a pediatric center there, there are 3 adult centers there. So I have other options that are now available because the child is older. So the other thing I look at is what kind of PH they have. So if the child has, for instance, congenital heart disease, I'll look for a transition that has access to an adult congenital heart disease program. If the person is an idiopathic, I want them to be at a center that has full resources, et cetera. So I always take into account what kind of disease and what kind of PH they have, like what food group they have, what classification, and then what other comorbidities they have. But it's one of those things that our team is very heavily involved in discussions of where our patients are going to go. I kind of feel like I'm sending one of my kids off. So I'm very, very involved in that process.
How about you, Mary?
So I'm at Boston Children's Hospital, and we are very fortunate because we're connected by a bridge to the Brigham and Women's Hospital. By virtue of my training, I actually care for children of all ages, and as well as adults, because I trained in pediatrics, internal medicine, adult cardiology, pediatric cardiology, and adult congenital heart disease. And I maintain board certification so that I can care for adults. So for me, transition is a very important topic because it really is preparation and readiness for independence. But patients may just transition from my pediatric pulmonary hypertension clinic to my adult clinic, which has different colleagues, different APP staff, and patients may be hospitalized at the Brigham and Women's Hospital instead of at Children's Hospital. But it's really a matter of transitioning a different day. But as well, one really has to think of other things that go along with care that are really important. So for example, transplant programs. So we transplant usually up until the early 20s here at Boston Children's, but then later on, we have a very close relationship with the transplant program at the Brigham and Women's Hospital, and work closely with those providers to think about transplant. Patients may have other associated illnesses, and we really have to choose their care providers very carefully. And at the very beginning of their teenage years, we start to work with children so that they are ready for transition. Do they know their medications? Do they know side effects of medications? How prepared are they to face some of the challenges of living independently, going off to college, and really thinking about their own care, taking charge, really having ownership of their illness. So transition occurs even whether it's the same provider, and we're so I feel so fortunate that I have the opportunity to care for patients here at all ages, but it occurs and is really important for our patients, whether or not they stay with me or are seeking care elsewhere.
And how about you, Dr. Hopper?
Yeah, we're also fortunate, of course, to have the adult Stanford PH program on the same campus, and that's our preference. And to what Nidhy was saying, I think we kind of prefer to transfer to people we know and to help that transition process be more seamless. They can walk over and see the clinic at the same visit, but we don't always have that luxury. I think a lot more in the adult world than in pediatrics. Sometimes insurance dictates where you can go. So we have had a number of patients who come a great distance, sometimes even from out of state. And when they transition to an adult program, the insurance says, yeah, we know you want to go to Stanford, but you actually have to go here. So we obviously work with those other programs, and thankfully we've been able to transition patients to other PHA accredited adult programs and have had those transitions work well. But I think that's one thing that can be a bit of a challenge.
And another question, Dr. Austin, that came in is, so what about kids that are or young adults that are transitioning to college, off to school in another area of the country? How do you work with them our families to that young adult to ensure they're getting the right care, no matter where their college of choice is?
Yeah, that's a really important question. Some of that for our group has to do with where they are in their diagnosis journey and where they are in their understanding, of course, and their family comfort with how things are going. So similar to what you heard before, we start to try and talk about transition several years in advance, and sometimes we'll even have a visit with here at Vanderbilt if they live close and they want to try and stay in the Vanderbilt system. Similar to Stanford, we can actually shepherd them to the adult side. But if someone, say, for example, is a more recent diagnosis, sometimes they need a little time to get in the groove with our pediatric group. And in those circumstances, if they're going away to college, we usually first try and find what city are they going to, or do they want to go to, what are the resources there, and what can they access? And if there's a really well-established adult program in that center, it often makes sense to transition them to that institution at another location away from us. In contrast, if we have people going to locations that are locales that are a little bit maybe smaller without the adult associate infrastructure or even a pediatric infrastructure, we will have a partner group there that we may work with, and we may be their primary still, but they will still see that group at a predefined interval. We usually see our stable kids every 3 months here. I think that's fairly typical around the country in pediatrics, at least. And so we'll maybe see them when we can, when they're home from their holidays, but then they'll have a check-in with a local team, similar to what we might do for an out-of-state person who has a local cardiologist or pulmonologist helping to manage their PH. So it depends, Steve. If we have a group, say, for example, the kid's going to Boston and they're a fairly independent and well-experienced child, well, we may just call Dr. Mullen and say, hey, how can we facilitate a child who's going to be well established in your region to move care to you? So it does a little bit depend on the child, how far they are from diagnosis, how comfortable they are, their neurodevelopmental comfort, and other things.
I don't know if we incorporated this a little bit in the discussion, but one of the questions that was here was typically, how long do you keep a PH kiddo with you? I know that range, we had that varies, but I'm just wondering if it's unique for each of you.
I think we're probably a little more, little on the earlier side than some programs. We tend to transition the majority of our PH kids between 18 and 21. I know some will keep a bit longer, but for all of the reasons that were mentioned, for us, it seems to work well to do it at that stage. And I've had a few teenagers for whom the process was actually really empowering. It sort of boosted them to get more independent and to kind of, get it together and take ownership and really embrace that independence. So for some of them, it's actually been a really good sort of maturing experience to transition out of the pediatric setting.
Yeah, I think you'll hear different things. I know you'll hear something different from Dr. Mullen, but here at Vanderbilt, we're similar, 18 to 21. For some people, we target 18. Some people, we just know it might be better for them to go when they're a little bit older, or they request it. We used to follow children much longer before the PHCC programs were established and whatnot. We're much more now likely to transition you by age 22.
Yeah, we're the same here at Texas Children's. And it's, I think it just naturally, even if for the kids who's not ready at 18, many of them, by the time they get to 21, or, like they're coming in by themselves, they're clearly adults, and their work schedules don't permit them to come, et cetera. So it becomes, I think, organic that by 21 is a natural time to transition, if you haven't already.
Can I ask, and I'm curious if you find this in the teens to young adults, a lot of, in my experience, you see sometimes there are kids, young adults that are, talk about their diagnosis. Then when they get into high school or whatever, they don't want to tell anybody about that. So is that a function that gets them into each of your eyes of how to transition these kids? Because Rachel, you said they were, oh, this could be empowering, but at some point it's like, make an emergency plan or whatever, as we were talking about. But like if a person is like kind of keeping that close to the vest to some of their friends and associates, is that a hindrance to this process?
Well, I think that one of the places that comes to the forefront is when students are starting to go away for college. And so we started talking about that very early, because someone else really needs to know, that a patient has, a nurse or medical team. They will be asking for health records. Sometimes students are accustomed to using supplemental oxygen, for example, at night, or mixing their medications. And then all of a sudden they're living in a new circumstance. And so we really try very hard to support our patients and families with that, so that they can make a successful transition to college. But I hear you that not wanting to tell people, and it's very understandable for young adults not wanting to start a new situation by talking a lot about their illness. It's something that we really support our young adults through.
I'm going to add to that. I think it's interesting, if you look at the transition tools, that's not one of the things that people have to check off on, right? It's not, have you told your close friends and colleagues about your disease? That's not a transition assessment. It's something that I think we would like our children to feel confident to talk about their disease, and to also know, as Dr. Mullen pointed out, that it's important to have an emergency network of people to talk to and to take care of you if something were to happen. But it's not something that we can really require. And I think many adults will know that there's a lot of people who we work with or interact with on a regular basis, but we know very little about their medical history, right? There is a confidentiality that comes with that. One other piece that comes up often is whether it should be disclosed when you're applying for employment. And I've had this come up even from my teenagers who are getting after school or summer jobs. And they've asked, I had a mother reach out to me to ask, should her daughter let the owner of the restaurant know that she has pulmonary hypertension, because that might affect her ability to, her endurance, her ability to, to stand and carry weight, et cetera. And she had posted this in a forum and got very mixed responses. There were many people who wrote in and said, you should never tell your employer about your disease because of fear for discrimination, or just differences in how in your job, kind of like what you're allowed to do. And then others said, yeah, you definitely should, because you're there and something could happen. What if something happens? So I think it's not clear cut, and I think it's a very personal decision of what people are comfortable with. What I do hope is that these questions and concerns about, should I disclose this to people, and how will they react, and what if they judge me? And I would hope that these are themes that could be discussed in either their pediatric home or their adult home, wherever they are, because I think a lot of us will have experience with it and can hopefully counsel through that.
Wonderful. Well, I'll tell you, let's kind of move this conversation to clinical trials in this patient population. And it's kind of an this is like, as we say, a time that they're eligible for a lot of these adult trials. And I'd just like to look at your worldview, how you address the trials in this patient population, either through individual trials that you're doing at your centers or through collective ones that you do through PPHNET registry and whatnot. So we could talk about that for a while. And if anybody has questions about that, please remember to raise your hand or stick it in the chat.
Rachel, you've been leading us so much as a group on this. Will you start and I'll follow up, or vice versa?
Sure. Yeah, I think, as I was thinking about this topic ahead of time, I was sort of struck by the fact that we've actually had a number of adolescents participate in the trials that we've done, the multi-center trials, either pharma-based or PPHNet-based. But doing a little survey on clinicaltrials.gov, all of the adult trials start at 18, right? And so in our minds, as was mentioned earlier, there's very pediatric specific type pulmonary hypertension, and then there's idiopathic or heritable pulmonary arterial hypertension that may look very similar when it's presenting in a 16-year-old versus a 25 or 35-year-old. So that artificial sort of cutoff at 18 is really more driven by the legal, ability to consent for trials. In a perfect world, I think it would be great if we could include, 15, 16-year-olds in adult trials. And probably vice versa, if we extended our pediatric trials up a little bit older for the right patients and the right populations. But I think we're sort of, our hand is forced by that legal consenting age of 18 and the logistical challenges of running a pediatric trial versus an adult trial.
Well, to the doctors that you say you do keep patients, that you just keep seeing them for a while, in Mary's case, for example, when do you start bringing those kind of discussions in? And I'm curious also, as a kind of a second part to that, is do you find in these younger adults that they're kind of status quo, they don't want to change the playing field, maybe as if you would have an older adult?
I save time at the end of each visit to talk about things that are coming down the pike. So we have the mass pike here, and we talk about that. What are new medications? What are new clinical trials? What are things they might be eligible for? How can they participate? And so we've had excellent participation over the years from our older patients, because they're really eager to think about new things and to engage in those. And so I think it's really important for us to keep thinking that as our patients emerge from adolescence, as they become young adults, that they are eligible and they are really thinking about innovation in the field and about new things. So it's really important to reserve some time to mention that, anticipate it well ahead of what's happening.
That is such an important point. I love the mass pike reference, Mary. That's great. One of the things that it reminded me of that we've navigated more strongly lately at our center because of the interest in, for example, the sotatercept trials that have been ongoing. One thing for you to keep in mind is that if you're thinking about an older age adolescent who's not yet transitioned but approaching that, some trials maybe, even if you have a PHCC pediatric center and a PHCC adult center, as we have here, we don't automatically get involved in the same trials. So the sotatercept trial, for example, not to highlight just one, but just realistically is one that we recently had that went down to people who were young adults. Well, in our center, our group, myself and my partners, Dr. Sullivan and Anna Brown, were not actually site investigators for the adult trial. And so we did have individuals for whom we had discussions about whether they should go over to the adult side, either to be part of that trial or to transition so that they could be part of that trial. And sometimes the time of transition is a tough time to get in a trial. If there's some slight variations in care practice or other things, you might not be as suitable for a trial enrollment, depending on the strict or not regulations around a trial. So one thing that you want to think about is, I'm interested in that upcoming trial. I talked to, Mary, Dr. Mullen in clinic, and she said, coming down the pike is X. Well, I'm about to be 18. Is this a time that I should be thinking about not only my care, but my eligibility for trials and where one might access the trial most effectively, if that makes sense? So for example, a lot of pediatric focused trials have pediatric investigators who are people on this call and other pediatric providers, whereas adult programs often handle their own trials. So something to think about.
Well, to that end, it's interesting that the way you phrase that, Dr. Austin, that if somebody's transitioned to an adult program, do you generally want to see some kind of like, get them established, get some kind of baseline going, other than to say like, hey, I'm in here today, I've transitioned over, they walked me across the bridge or whatnot, and now like put me in trials X, Y, or Z? Is that because the adult team might not be as familiar, they don't know how things are morphing or changing along the way? I don't know if
Well, they
that's
probably are really
the way I've said
experienced
that.
with, no, you said it right. They're probably really, of course, comfortable with the care paradigm, but they may not be comfortable with that person and what has their journey been. And so they may not be as comfortable with the ups and downs of a given patient or person's experiences. And so they might want a little time to get a groove together. That time for groove together, you might miss an opportunity to be in a trial that may have limited enrollment. Nidhy, I saw you nodding. I think I interrupted you. I'm sorry about that.
No, I'm agreeing with you. You're singing my tune. I think that it's important to know that these are some of the differences between pediatric and adult centers, and these are some of the strengths that I think adult centers have. And transition can be a really exciting time because of that, because you get to really advocate for yourself and have access to trials that perhaps you didn't before, and learning about them and knowing when the right time for you to enroll in that is also an important conversation to have with the pediatric team. I wanted to kind of tack on to this discussion that just because there's a trial available to you, like Dr. Austin said, during transition may not be the right time for you to enroll into a trial just because you meet the age cutoff, right? Sometimes for certain trials, you need to get off medications to wash them out before you can start another medication. You may not be the right class. I mean, there are a lot of other factors that go into deciding when someone's ready for a trial. And so just to get into a trial should not by itself be a reason to transition, because we certainly want to make sure that you're stable before you transition. So it's something as a factor to consider as access to trial, but not necessarily should be the governing thing.
One question that came in from someone who's watching, who's listening in Canada. It says, are Canadians ever invited to participate in US-based trials? My PHer is almost 18. I think, Dr. Austin, you said you wanted to address that.
Oh, I just wanted to make sure that it was addressed because I accidentally hit it. But yeah, basically, most trials don't have restrictions about where you live. The restriction is who is the investigative team, in this case, us or other people who can enroll them. So if your individual son is able to, or family member is able to establish a relationship with any site that is in the trial, they could be assessed for appropriate inclusion. Sorry about that.
No problem. And maybe I don't.
Yeah.
Oh,
and I'm just gonna add more and more. The trials that are being led by pharmaceutical companies are actually international. So I think we're seeing that more and more, that it's really a global effort, especially when it comes to pediatrics, because the numbers are so small. I think the pharmaceutical companies have recognized that they need to extend reach widely to multiple countries to be able to enroll enough patients.
And can I ask any of you, I'm not sure how this fits into the whole thing, but in the world of PPHNET, how your registry works in conjunction with trials, investigative or otherwise, if you could talk a little bit about that.
Dr. Mullen, can I take that one?
Sure, I can talk a little bit about that. The registry contains patients who are diagnosed with childhood pulmonary hypertension, but it follows them forward. So it contains young adults with pulmonary hypertension, or even slightly older adults now. Through it, we really have had the great opportunity to see that we have patients who've been treated with parenteral prostanoids for 10 or 15 years or more, that we have emerging populations of children with developmental lung disease like congenital diaphragmatic hernia and bronchopulmonary dysplasia who are older and are emerging and becoming eligible for adult care. And so how does it really work to align with clinical trials? Well, it's a registry that continues to enroll both new and incident patients from numerous centers. It has the potential to be something that we can actually look at and say, we have this population that could potentially be eligible for a clinical trial. That's in theory. In practice, we have not, we've used it a little bit in tests, but in future, we certainly could use it in that setting.
Yeah, and I think that's one thing we're all really excited about in terms of the potential of things like this registry to be able to gather real world data, longer longitudinal data than you get in a trial, which is usually 24 weeks, and then they stop kind of collecting data and they publish it, and that's the end of it. We have a really unique opportunity to follow our patients long term, and I think we're just sort of scratching the surface in terms of what we can do with our registry. And so that's the big goal of our network moving forward, is to be able to really continue to follow our patients, to figure out what the endpoints are that we should be looking at, and how really to use this data to improve care.
A question came in. I don't know if this is a duplicative answer, but it says, as a parent, I had in my mind that we would look at trials as soon as we transitioned into adult care. I guess I didn't realize how restrictive the qualification criteria for trials were. So, what is kind of best advice on that? They should just be someone that's interested in that, the patient, the family. They should just be looking at the kind of inclusion or exclusion criteria, or anything else, just as they kind of approach that?
I think that's a great question. Maybe since I inadvertently caused that concern, I'll mention it. So every trial that's designed it has certain criteria that they're looking for the individuals to be in that trial. And that includes what type of pulmonary hypertension a person has, perhaps what's their functional capacity or status, what are features of their health or their difficulty going on. And so every trial is a little bit different. They also have different, sometimes age group desires, especially in pediatrics. They have groups of age groups, but in adults, it's more commonly lumped as a larger, just 18 to 60 or something. And every trial is not available at every site. So different sites offer different trials, and those negotiations and trial launches are vary according to whether the trial is sponsored by like a government agency like the FDA or the NIH or the National Institutes of Health, or a trial sponsored by a company. So every trial is different, and not every trial is offered at every site. Every individual who's seen at PH centers is then screened and looked at to see if they would be appropriate for a trial participation or not. And so it's a great idea to be aware of opportunities that you could raise your hand and say, don't forget about me or my child or me as a patient, as an adult. So you could go to Dr. Hopper-Richel mentioned clinicaltrials.gov has lists of trials that are offered, and you can put in terminology and look for trials and offerings in your area. So it's always good to be on the ball and to be thinking carefully about that. Generally speaking, one other thing I would say is trials, for the most part, of novel new therapies are relatively geared toward including people who are relatively stable. That is to say, they're not having a lot of changes in their medical care, because the initial evaluation wants to make sure that we look at a person who is relatively unchanged. Can we improve them without harming them? And that's hard to determine sometimes for people who are having a lot of ups and downs. So I hope that makes a little bit of sense, but being your own best advocate for understanding what's available in your area is a great start. And then talking to your provider, like you heard about the pike, what's coming down the pike is a great way to think about it too.
I'll say as a side note, this is on our website, phaware.global. On our homepage, we have a clinical trials matching tool, which is tied to clinicaltrials.gov, which is
Awesome.
just hundreds of things, as you can imagine. But if you enter in some basic information, a handful of questions, it basically zeroes in on ones that you are in theory pre-qualified for and are in your area geographically, however big the circle or radius you want to have. So I'd encourage you to look at that. I think as we're winding down here, I just want to reiterate all these doctors are working today, have come out of clinic. So we're so grateful to have you. Are there any other questions that here in the last couple minutes here that we want to pose to this team of docs? Or doctors, if you want to, if there's any kind of summation to all this, feel free.
I think one of the things, and it's kind of like what Eric was saying just now, is that don't be shy to bring up these themes with your team. If no one has introduced transition to you yet, it is fine for you to ask about that, to ask when are we looking at transition and what's that process like, etc. Sometimes when you're taking care of pulmonary hypertension or when it's any chronic illness, sometimes we just get so into the management of the disease, and then you look up and you're like, oh my goodness, when did you turn 16? Because I think we're just kind of like doing the appointments and we don't necessarily realize how the time has flown. So, and I think as parents feel the same way too. You look up and you're like, when did my child get to 16 or 18? So if these themes haven't been brought up for you yet, please bring them up. If you learn about a trial and you're wondering, would my child be a candidate for this trial? Ask, and if there are a lot of things that I learned from my patients and their caregivers and families and parents, because you learned about it on social media or you found out about it on clinicaltrials.gov, and that helps me be a better advocate for you. So just don't be shy to talk about these things, and by you, that could be the parent, the caregiver, or the patient, right? So if you hear about something and you're wondering, would I be good for this? Ask. And if we don't know the answer, then we'll find out together. Well, I will let all of you get back to helping these great patients, and I thank you so much for joining us here today and answering all this great information about trials and transitioning. I do want to give another shout out to PPHNET, where they went through a very big website redesign. They have all kinds of resources and new content. Again, that's pphnet.org. There's a whole subsection on friends of the PPH network, families, patients, community. We actually shared all of our pediatric centric content of our podcast series and videos to there as well. We'll send this a video of this afterwards and to have there as well, and also post it to our PHAWARE social sites. But doctors, thank you so much. I really appreciate you taking the time today. Thank you so much.
Thank you so much.
Awesome. And, it's the end of the year. I will say our 2023 sponsors, PHAWARE, we really thank everybody at CVS Specialty, Enzavant, Janssen, Liquidia, Gossamer Bio, and Merck. So thank you all for joining, and we will see you another time. All right.